Welcome back to the Rehab Exercise and Sports Therapy Podcast. This is episode 4. I am pleased today to be joined by Dr. Ramin Tabaddor, who is kind enough to come on the podcast. Dr. Tabaddor, if you could just give us a little bit about your bio and what your interests and specialties are.
Yeah, thank you, Dan. Thank you so much for having me, by the way. I'm super psyched to be doing this. I think this may be one of my official first podcasts. So,
Oh, awesome.
yeah, so you're breaking me in. You're
All
breaking
right,
me in.
excellent. We'll be gentle, I promise.
Yeah, please do go easy. So yeah, I am a sports medicine fellowship trained orthopedic surgeon over with University of Orthopedics. I wear a lot of hats right now. I'm the chief of orthopedics at Kent Hospital. I am the head orthopedic surgeon with University of Rhode Island Athletics, and I'm now the co fellowship director of sports medicine fellowship program at Brown. Um, and yeah, so I pretty much treat all sorts of sports related injuries arthroscopically and non-operatively when I can. But I have a special interest in hip and pelvic disorders. That's kind of been what's been near and dear to my heart from the beginning of my training, and that started in my fellowship. So what does that mean? Like a lot of complex, strange, weird hip and pelvic disorders, such as athletic pubalgia, otherwise known as sports hernia, um, femoroacetabular impingement, otherwise known as hip impingement, gluteus medius tears, iliopsoas tendinopathies, pudendal nerve entrapments, sciatic nerve entrapments, hamstring ruptures. So really all the stuff that most other people don't want to deal with, I think,
Yeah.
kind of get thrown to me, and I try to figure out what to do with that.
Yeah, excellent. And obviously that encompasses a wide, diverse range of things. For the podcast today, we wanted to kind of pick your brain a little more specifically about FAI, just because
Fantastic.
obviously within the last 10 to 15 years, that's an area of orthopedics that's just kind of exploded. And unfortunately, as much as like the surgical literature continues to expand, I feel like the rehab literature is definitely lagging a little bit behind. So definitely wanted to get some of your thoughts about that today. But specifically with regards to FAI or femoroacetabular impingement, if you could, because the hip is such a diverse area, like we just alluded to, obviously there's a ton of symptoms that can overlap and can kind of mimic FAI. So I was hoping, can you take us through your process a little bit as far as what typically you're screening for and what your algorithm is for kind of making that differential diagnosis to kind of rule in FAI?
Yeah, so that's a great question, and it's a really difficult question.
Yeah.
Yeah, so the problem is when you're dealing with hip and pelvic disorders and issues, there's a broad differential. So typically when
Sure.
I give talks on this, I'll put a slide up, and the slide will have a differential list that's typically like 4 columns,
Right.
the whole page through, and it's because it kind of encompasses and spans like lumbar pathology and visceral pathology, so urologic or gynecologic. It can span knee issues that could be causing retrograde pain up to the hip.
Right.
It could be, gastrointestinal issues or general surgical issues, inguinal hernias. So you really need to kind of like think outside the box of orthopedics and really try to understand like the anatomy, the complex structures, the interplay, the biomechanics to really kind of hone in on what exactly is the source of pain, and is it truly FAI as the main source of pain for this athlete? Because you don't want to just anchor onto something that you think is there because that's what they're there for,
Right.
and miss something else that's truly the issue, and that could be really kind of a devastating problem. So yeah, it is tough. So when a patient comes in, basic principles of medicine as a healthcare provider for everything that you and I both do, which is okay, get a history. The history has to really make sense. Go through a very thorough examination, understand the anatomy, understand kind of where the pain is coming from, and how does that align with the history. And once you kind of put those two together, you can really start to kind of get a picture of kind of what is actually happening. Is this truly an FAI type scenario or situation? And if so, how do you proceed from there? Um, one of the issues is that FAI is a great masquerader.
Right.
So people who have FAI it can be potentially an iliopsoas impingement, or it can mimic low back pain. It can mimic. I've had patients who've seen neurologists for FAI because they thought that they had like testicular torsion,
Yeah.
or like a hydrocele. So yeah, I think it's really important to understand like the nuances of it. So I'm very regimented in terms of how I go about my examination, making sure that it's very structured, it's very methodical. I go through it the same way every single time from beginning to end. So just making sure there's consistency with what I'm doing with these athletes and these patients.
Yeah. So, I mean, on that note, I mean, we know that like it's common for a lot of these, even though FAI may be the primary pathology, to have hip flexor tendinopathy or glute tendinopathy or that kind of thing. With respect to imaging, I'm wondering like if you could lay out for kind of not, I won't say the layperson because that's probably not the accurate term, but for kind of the general provider, what are the kind of most critical elements in terms of imaging to help kind of really determine at what threshold FAI is? I mean, things like alpha angle, center edge. If you could kind of, tell us what your preferred imaging is and where the cutoffs are and that kind of thing.
Yeah. Okay. So just to take a step back, and just to review like very quickly, like FAI in general, right? I mean, we know that FAI is a mismatch of the ball in the socket, and
Yeah.
it's either like an overgrowth or overhang of the socket over the ball, or there's an overgrowth of bone on the neck of the femoral head. And so there's that abnormal contact between the two, and you're trying to gauge how much of an abnormal contact is there, and if there is an abnormal contact, is it primarily coming from the acetabulum, the femoral neck, or both? So those are the things I'm trying to evaluate and gauge on plain films. So in the most simplistic terms, and trying to keep things as simple as possible, which is how I try to run my practice.
Yep.
Start off with a weight bearing AP pelvis. It is absolutely critical that it's a weight bearing pelvis, not a supine pelvis. And because you want to know what is the status of the joint space itself.
Right.
Uh, Two, you want to know what the pelvic tilt is when they're
Yeah.
standing, because understanding the pelvic tilt while they're standing gives you a much better understanding of what their overall like muscle mechanics are. What are their core mechanics, what muscles are firing, where they have deficiencies. So a weight bearing AP pelvis, just for me to kind of get a broad stroked view of their pelvis. Is there any pelvic obliquity? Is there anterior or posterior pelvic tilt? Something we call ischial spine sign, where if you can see the ischial spines, that typically means that there's an anterior pelvic tilt, because you shouldn't be able to see those ischial spines on a regular weight-bearing AP pelvis. I'll look at the pubic symphysis to see that there's no osteitis pubis,
Right.
because when patients have FAI, their altered mechanics will shift through other areas of the pelvis,
Yeah.
such as the SI joint or the pubic symphysis. So it's important to see that. And on the AP pelvis, I will look at the amount of overhang of the acetabulum using a lateral center edge angle, which is basically an angle in which you make a line from the center of the femoral head straight up, and that line is then subtended by a line that goes to the lateral edge of the acetabulum, and that angle tells me whether they have a pincer impingement or not, or if they have dysplasia or not. So
Right.
the angle you typically want to live in is somewhere between 25 to 35 degrees of coverage. If it's below 25 degrees, you worry about dysplasia, and if it's above 35 degrees, you worry about impingement, pincer impingement.
Yeah.
Um, then I'll get a frog lateral, and the
Okay.
frog lateral kind of gives me a sense of whether there's a cam lesion, if there's overgrowth. And I'll use an alpha angle. And so you make a perfect circle that wraps around the femoral head, and that circle should encompass the entirety of that head. Any bone that starts to come out of that circle is typically a cam lesion, but the amount of bone that comes out of that is really what determines like the degree of the cam lesion.
Right. And that's alpha angle. I mean, am I correct? Am I oversimplifying if I say alpha angle essentially measures the roundness of the femoral head, like the
That,
sphericity.
that that's correct. That's
Okay.
correct. And so
All
like
right.
we talk about like what angle the bone comes out. It's kind of hard to without a visual, like explaining it verbally, like what it is. But we talk about alpha angles of like 55 or greater,
Yeah.
which is indicating like at what point the bone comes out of that perfect circle.
Got it. So on that note, we know that there are a huge number of quote unquote, you know, FA or CAM impingements out there that are not symptomatic, right? Um, in terms of your process for being able to differentiate at what point it becomes pathologic, and matching that to what you see clinically, how do you go about that process for you? Especially since so many of them are bilateral, right, with changes. And I want
Sure.
to kind of, I don't want to get ahead of myself, but I want to pick your brain a little bit about how some of those adaptive changes happen in a little bit. But if you can just let us know a little bit about your process with that.
Yeah, so it can be really difficult because you get a plain film and you see this large cam lesion, you want to automatically kind of anchor to that, right? You want to
Right.
automatically assume like, okay, that's the source of the pain, that's the issue. But it has to make sense. It has to kind of align with the complaints and their history. It has to align with the findings that you have on their exam, limitations in internal rotation, um, positive anterior impingements or positive Faber, you know, are they um, uh, what kind of pelvic motion do they have? Because when they start losing motion in their femoroacetabular joint, they start to kind of get some stiffness elsewhere in their lumbar spine as well. So kind of like looking at their overall mechanics to determine like, is that a symptomatic cam lesion or not? Because it's really amazing how many like young people and actually older people as well like adapt to these changes
Yeah.
anatomically, and that they live in perfect harmony with it and will never have a problem until all of a sudden one day they're 55 and they have a problem, you
Yeah.
know,
Right.
um, and because they have now arthritis. So we have to be really careful in assigning kind of blame on cam lesions that we see because it has to again align with the history and the physical exam.
Yeah.
Now,
So I'm
yeah,
sorry, go ahead.
if I have any like concern about like, okay, I think it's coming from the joint, I think it's coming from this cam lesion, I think the interarticular pathology is present, that's where I will really kind of lean on like intra-articular injections to at
Okay.
least guide me, right? So if there's any kind of question about it, like if it's not like glaringly obvious, I'll send them for an injection and do an anesthetic challenge and see how much relief they have of their symptoms. And then once they get that injection, I say, hey, look, for the next like 6 to 8 hours, go crazy, like go test it out, see how you
Yeah.
feel and report back to me. Keep a little diary, like how much improvement did you have? What did you have improvement with? What did you not have improvement with? And that gives me a lot of information to work off of to determine like, is that truly the source or is it really more extra articular?
Yeah. Okay. Well, so I want to pick up a little bit on what you just mentioned with the clinical exam, if I could, if you don't mind. You mentioned Faber test. Well, obviously, the gold standard out there, quote unquote, for clinical testing, right, is the Fader test, right? Flexion, adduction, internal rotation. But I feel, personally, anecdotally, I feel like the problem with that is there's a lot of other symptoms that can be set off by that test, right?
Sure.
If
Yeah.
somebody's got like a really irritable synovitis or that kind of thing, or hip flexor tendinopathy, a lot of times when you're compressing everything together like that, that's going to reproduce some of those same symptoms. So, is there a best clinical test for you, or something where you really kind of hone in on clinically, to kind of correlate to what you see imaging wise?
Yeah, that's really tough and super nuanced, because you really hit the nail on the head in terms of like how many positives you can get with a
Right.
FADIR, right?
Yeah.
And the FADIR has a lot of monikers, right? It's like the anterior impingement, the scour sign,
Yeah.
depending on how you learned it. But basically, you know, and this is what I teach like my residents and my fellows and my med students, like when you do a provocative maneuver and it's positive, you need to make sure you understand where it's positive or what it's positive for. Ask the patient, okay, where did that hurt? because I'll give you an example. Like a Faber is a very good example of that, and then I'll circle back to the Fadir. But
Yeah.
when you do a Faber test and someone says, "Oh yeah, that hurts," okay, where does that hurt? Like that could hurt in the groin, it could hurt in the low back, it can hurt in the greater trochanteric region, right? And all of them have very different implications
Yeah.
for what the potential pain source and diagnosis is. So the mere fact that someone says "ow" when you do a Faber doesn't really tell you much. You have to know like
Yeah.
where the pain is, right? Because it could be SI joint, it could be greater trochanteric pain syndrome, it could be internal impingement, it could be their psoas. So same thing with a Fadir. When I do a Fadir with a patient and they say "ow," I ask them, okay, where is that pain? Where are you having it? Because sometimes people can have gluteus medius tendinopathy, and they can have pain in their greater trochanteric region
Sure.
when you bring them into that position, and so you can get fooled. The same thing with the psoas, right? The psoas is getting pinched while you're doing that. So, and you also mentioned the hip flexor, like the rectus, right? Because
Yeah.
you're basically kind of crushing that rectus femoris tendon
Yeah.
when you're doing that. So what I will do when I take them through a Fadir is one, ask them where the pain is, if it's positive, and two, I will put my finger on these specific anatomic locations and basically try to kind of like neutralize them to see if it makes it any better. So if I put my finger on the rectus femoris tendon and then take them almost like a like a strap, like when you use like one of these
Yeah.
lateral epicondylitis straps,
Yeah.
right? So I'm basically using my finger to kind of neutralize the rectus femoris while I take them through the FDIR and say, okay, does it now hurt? And they'll say, actually, no, it's less. Or same thing with the psoas. I'll put my finger on the psoas and once again say, hey, does this hurt or does this not hurt more? So that gives me an idea or a sense. I try to eliminate by actually palpating these various regions that could also become symptomatic with a positive FDIR.
Yeah. All right. Thank you. Next question for you. You touched on it a bit already as far as the differences with imaging in terms of teasing out, is it pincher, is it cam, or often I'm sure there's probably quite a few scenarios where it's a combination of both, right? How in terms of different genders. Well, I guess in terms of frequency and genders, what do you see with respect to the type of FAI that they present with?
Yeah, so cam deformities are much more prevalent in men
Yes.
and pincer in women. And yes, you will see mixed scenarios. Mixed FAI is going to be most common in men. And the ones that do have mixed FAI, they'll typically also have like an os acetabuli, which is like a broken off piece of the acetabulum from chronic impingement.
Got it. Okay. We alluded to it a little bit already, but some of these changes that we're seeing, the literature kind of shows that they're happening in adolescence at this point, right? That there's a window of adaptation for these changes to happen, especially with certain types, depending on what your preference is for activity, right? Like sports requiring a lot of change of direction or that kind of thing. So if you could you give us a little insight into kind of how the pathophysiology develops and what type of adaptations you're seeing?
I can tell you about the theories of the
Yeah, sure.
pathophysiology.
Right.
Okay?
Okay, sure. Yeah.
Yeah. So this is thought to FAI is thought to develop at the time of like skeletal maturation,
Yeah.
when the growth plates are still open, and so for athletes, young athletes that are, and we know that these days, younger and younger athletes are engaging in much more intensive sports for a greater period of time over the course of the year,
Yeah.
right?
Specialization. Right. Yeah. I
Yep.
mean that's a whole nother podcast. We could
And that's
talk
a
like
whole nother
an
podcast.
hour on the
Exactly
good
right.
and the bad with that, right?
Exactly.
But yeah.
Exactly. All right. But this is one of the consequences. So when you have young athletes that are putting significant amount of stress on their femoral head growth plate, all right, upon the epiphysis, getting into certain internal rotation motions or certain extremes of motions, they're stimulating that growth plate, which is then creating excess bone growth in that region. And based on where they're getting contact of that growth plate and the epiphysis will determine kind of where that cam lesion will develop. All right. So that's the kind of prevailing idea. Like, there's also like the genetic predisposition
Yeah.
as well, that people will think of. There's also the idea that, there may have been like some defect, like a leg calf perthes that may have led to it as
Yeah.
well. But the prevalent is the stress on the growth plates at the time of skeletal maturation. And what happens is, over time, people will adapt. I mean, we all know how young athletes are so adaptable.
Yeah.
And they adapt by borrowing motion from other areas. So if they can't get motion through their hip joint, they'll get it through their SI joint, their pubic symphysis, and their lumbar spine. What they'll also do is they'll also change the mechanics at their knee, which is why there's also been some prevailing theories that athletes that are at higher risk for ACL ruptures are because they have less motion of their hip joint.
Interesting. Yeah. Um, so we talked about femoral head. I believe, correct me if I'm wrong, you can also see version of the acetabulum also, correct? Like to some of those adaptive stresses or
Yeah.
yeah.
So absolutely. But sometimes it'll work in a negative way. So like you'll have athletes that will develop a pseudo impingement. So those that basically will shift their pelvic tilt in such a way where their pelvis tilts anteriorly,
Yeah.
because they have poor lower abdominal core control. And so they may not have a true pincer, but now they have this almost like pseudo pincer, because what you've done is you've now created an over coverage scenario of the anterior acetabulum impinging against the femoral neck when you come into hip flexion.
Right. So like an adaptive postural strategy or adaptive postural syndrome, through the anterior pelvic tilt. Okay.
That's correct. And then they'll
Yeah.
end up getting a lot of like hamstring tightness, and they'll get changes in their lumbar lordosis. And I believe it was a physical therapist by the name of Jonda who had
Yeah.
kind of described this type of
Yeah.
phenomenon.
Lower cross syndrome, he called it. Yeah.
Correct.
Right.
Yes,
Yep.
lower cross body syndrome.
Yeah. So you just set me up perfectly with what you just talked about with some of those postural and adaptive changes. Um, Non-op rehab. Typically, tell me, like, how in your mind, how do you determine who's a good candidate for non-op rehab? Do you subscribe to pre-op rehab if you determine this person does have FAI? Tell me some of your thoughts about that. Like, because I know out there the literature kind of shows again that it's not horribly successful, but again, I feel like there's this kind of a scarcity of good literature that's been well done on it. So I'm curious to hear your thoughts.
Yeah, you're right. The literature is pretty cruddy
Yeah,
out
yeah,
there. So
yeah,
there's definitely a paucity of very high level data on this.
yeah,
Um, so in terms of like who's operative and who's non-operative, first off, you need to confirm that they actually, in fact, have FAI,
yeah,
and that they have pathology in there. Because one of the things we didn't comment on is beyond the imaging of just plain films, getting an MRI
yeah,
to determine like what is the extent of interarticular injury, such as cartilage wear and damage, labral tearing. And I don't do arthrograms anymore, because the technology has gotten so good, and the sensitivity and the resolution of these MRIs have gotten so much better, that I can not have to make this poor person suffer with an arthrogram,
yeah.
determine that. So we're having this conversation, I think, based on having already established that there is FAI, correct?
Yes, I'm sorry. Yeah,
Okay.
I'm making that general assumption. Yeah,
Okay.
sorry.
So knowing that there is actual FAI and there are things going on inside the joint, I think one is, how symptomatic and how limited are they? You know, can they kind of manage and live with their symptoms that they have? Are they kind of mildly interfering with their daily activities, or are they having a very major impact on it? Two is, if they're an athlete, are they in season or are they out of season?
Right.
Because if they're in season, well, what can we do to try to get them through the remainder of the season safely? Because that's really important to them. So if they're not terribly symptomatic, and they seem somewhat functional on their exam and by their history, or they're an in-season athlete, then I will absolutely try non-operative management.
Yeah.
And non-operative management will really focus on looking at their core mechanics, trying to re-engage their lower abdominal core, get their pelvic tilt back into a neutral position, work on like lumbar stabilizers.
Yep.
They typically have a lot of glute weakness, so really working on glute med activation and strengthening. And it's amazing how far that can actually get them. And and I tell them, I say, look, if you end up having to go to surgery, everything you end up doing right now is going to help you postoperatively anyway.
Yeah.
Because if I do feel you're an operative candidate, I find a lot of value in preoperative PT.
Yeah.
I think it's good for the physical therapist to understand the mechanics preoperatively, so they have a frame of reference. They can establish a baseline, and then be able to work through to the postoperative phase.
Yeah. Yeah, I mean, I tell some of these patients all the time, whether it's, I mean, we can talk pre-op rehab for anything, but especially for hip, right? That, yeah, again, you can go in and you can shave down some of the femoral head and that kind of thing, but that still doesn't change some of the adaptive soft tissue changes, right? And some of the kind of default neurologic postural patterns, like you mentioned, the anterior pelvic tilt and that kind of thing. So I usually tell them there's only upside to it, same kind of thing. Yeah.
Yeah, I mean, it's honestly amazing how many of these athletes have poor abdominal, like lower abdominal core strength,
Yeah.
and their glute med strength is like essentially non-existent.
Right. Now, how much, I'm curious to get your thoughts, how much of the impact on some of the surrounding hip musculature, whether we're talking glute, hip flexors, whatever, or adductors, I mean, we'll lump that in as well because we see some weakness there. How much do you think is related to like a painful inhibition, and how much do you think is like, obviously this is a chicken or egg kind of question, but how much do you think led to some of the poor mechanics and that kind of thing to begin with? I'm curious.
Yeah, so I don't think the poor. Are you seeing me right now? Sorry.
Yeah, I see it. Yes. Yeah. Yep. We're good.
Yeah. So I don't think that any of the poor kind of muscle mechanics can obviously lead or create any of the bony abnormalities, right?
Sure. Right. Yeah.
So I really do think that a lot of the muscle issues and tendinopathies that they get are adaptive. So I think like
Yeah.
a lot of these athletes get glute med tendinopathy, and they also get TFL tendinopathy because of the way they're trying to adapt,
Yeah.
and trying to compensate. They get adductor longus tendinopathy, and then they get the stress across again. They get the stress across the lower abdominal core. So then they start developing athletic pubalgia. And
Could be big
there's
too. Yeah.
a there's a significant amount of literature correlating and associating athletic pubalgia with FAI,
Okay. Right.
and the importance of recognizing the coexistence of those.
So for the in-season athlete, aside from rehab, what other kind of go-tos are you going? You mentioned intra-articular ejection. How often are you trying to implement that just to get them through their season?
Yeah. Okay. So if I'm kind of going beyond the diagnostic injection and I'm really trying to do, let's say, a therapeutic injection, I'm very
Yeah.
judicious about that.
Okay.
I will use that sparingly. So let's say you have like the athlete that's in season. They're like, look, playoffs are coming. I'm a starter. I just need to get past this, or it's my senior year, and this is really important to me. Then yeah, I'll do a cortisone injection to help them kind of symptomatically get through. And again, just not relying on the injection, like working with their
Sure.
trainer, working with PT to kind of work on their mechanics as well,
Yeah.
and then get him through to the end. But I will not kick the can down the road and get into a pattern where I'm just repetitively doing injection after injection after injection.
Yeah.
I think that's a slippery slope, and it leads to a very bad outcome for them.
Sure. Yeah, no doubt. So you're just using it as an adjunct, essentially, to some of your other
I use
treatment.
it. I use it as adjunct or in special
Yeah,
situations again to like help them get through the season, knowing that hey, when the season's done, we're doing surgery.
we're gonna fix it. Yeah. Okay.
Yeah.
So on that note, that's probably a pretty good segue. If you could tell us a little bit about surgery, and if you could, because I know again, we talked about how there was a kind of explosion of hip arthroscopy in the last, let's say, 15, 20 years. Tell me a little bit of, if you could, about how the surgery has evolved, and what you're, again, obviously, it's going to be a case by case basis, but tell me a little bit about your kind of surgical process, if you could.
Yeah, so I still think hip arthroscopy in general is still in its nascency. I
Yeah.
think we're still learning a lot about what we're doing, why we're doing it, how much we should be doing. I'm a minimalist. I've always been a minimalist.
Okay.
I always feel like less is more. So when I identify an operative candidate, I need to understand. Okay, is this a cam lesion? Is it a pincer lesion? Is it mixed? All right. What's the extent of the labral pathology, and is there any underlying cartilage damage as well? Right. So
Right.
it gives us a set of expectations going in there. Now I have a strategy. Like, what am I going after when I go in there? Because I don't want to make it up as I go while I'm in there. Once I'm inside someone's hip joint, and I only do two portals. Okay, so I don't.
Okay.
People I think used to do three portals. Some will do
Yeah.
four. For me, I'm able to do everything just through two portal sites. Uh, and when I get inside the joint, and I first I do my diagnostic, evaluate the degree of arthritic degeneration or cartilage wear. What's the labrum look like? How much of a repair am I going to need to do? And then how much pincer am I going to have to take down, and how much cam lesion am I going to take down?
Right.
Um, if I can, it is absolutely critical that if you can repair the labrum, repair the labrum. It is that the literature is very convincing on debridement versus repair.
Yeah.
Debridements just do not do well. If it comes down to a debridement and they're a young athlete, then augment with a reconstruction.
Yeah.
Whether it's a segmental reconstruction or a complete reconstruction. And I think that's really critical. And I typically we use cadaver iliotibial band.
Okay.
Um, and so once I, because it's important that FAI it's a bony abnormality. It's a bony problem. So if you just fix or address the labrum in isolation, you didn't really fix anything,
Right.
right? So you need to restore the anatomy, and that's what's really critical. Um, and then oftentimes with these athletes, their psoas, because of their constant, their chronic anterior pelvic tilt, they get a contracture of that iliopsoas.
Yeah.
And so that psoas will impinge along that medial column of the joint. And then you actually see tearing and bruising of the psoas adjacent to where the iliopsoas passes through. So I will oftentimes do an iliopsoas release.
Release. Okay.
Um, at the level of the joint, the iliopsoas is 50% tendon, 50% muscle. So when you're only releasing the tendon portion, you're truly doing a lengthening. You're not tenotomizing it. You're not causing any weakness. You're not changing really the mechanics. And I haven't seen weakness in any of these patients that I've done these releases in. Once again, judicious about who I do the releases in. But if the psoas is literally staring right at me inside the joint, they're going to get a release.
Okay. So correct me if I'm wrong, like it used to be a lot of surgeons were leaving the capsule open, right? And that trend is now reversed to where most people are closing it up, right? And trying to minimize any adhesion or scarring or that kind of thing. Um, Tell me a little bit about some of the, I guess, the surgical pitfalls that we see, or some of the complications you might run into, if you could.
So just to touch upon the capsule closure, that is still very controversial, and there's
Okay,
still there's still no consensus on that.
got it.
And
Okay,
so the pendulum swings back and forth probably every couple of years.
got it.
And so personally for me, when you have let's say a ice hockey player with this massive cam lesion, they've got a pincer lesion too, so pretty large FAI, they've got a tight hip. I try to distract them just to get into the joint operatively, and I struggle just getting in there because that capsule is so contracted, and it
Yeah.
heaves. That to me, the capsule is part of the pathology, and so doing a capsulotomy and a capsular release, and then leaving it open is part of the treatment, in my opinion.
Okay.
All right.
Yeah.
Um, Now, if I have a female that may have some sign or element of instability that I'm concerned about, then what I used to do is I used to do a capsular closure. What I do now is I do what's called a periportal this is kind of a trend that's been developing, but I do a periportal capsulotomies, which means that I make my portal site, which are
Yeah.
tiny, tiny little poke holes, and then I open up the capsule just ever so slightly around that portal, enough to maneuver and do the work that I need to do, so that I have not violated the iliofemoral ligament or the
Yeah.
ilioinguinal ligament. So there's nothing really to close. I've kind of maintained their anatomy. And so I think a lot more people are starting to do that, but I've been doing that now for the last probably like 6 years. I think I was one of the earlier people to start doing that.
Okay. So that you keep like prompting me here and setting me up for all these great things.
I
So
do what I
if
can.
you could tell us a little bit about that whole concept, because you mentioned females and the issues around iliofemoral ligament, that kind of thing. So tell us if you could this concept of hip kind of especially anterior hip microinstability. I feel like is something that has probably been going on for years, and I know I probably have missed a bunch of times it's seen me and I haven't seen it. If you could kind of tell us a little bit about that, the anterior hip microinstability and the impact of that on the pathology to begin with, but also some of the impact on success, post-surgically.
Yeah, I think I'm still missing it, honestly. I mean,
Yeah,
it is really difficult to kind of pick up on, and sometimes you just need to have like a clinical suspicion of it. Um, you can have females that have a cam lesion in the setting of dysplasia, which is really tricky,
yeah,
really tricky. But I think you need to understand, like when you're going through an exam, you're getting a history. I think it's also important to kind of like know where they fall on the Beta and laxity scale.
yeah,
So for me, like that's important. I always try to kind of document the beta and laxity scale and understand like, do they have other findings or signs of like instability? You
mhm,
also can get a sense just on their hip motion examination, right? Like they may not have dysplasia, but I can internally rotate their hip to like 60 degrees or 70 degrees, and it's like that's not normal or natural, right? So that's
yeah,
not happening. That's not happening because of lack of bony constraint. It's happening because their capsule is allowing that.
right,
Um, and so yeah, so I think capsular microinstability is a big deal, and I think that that can lead to some unsuccessful surgeries and outcomes. So you can do everything right in surgery. You can even do a capsular closure, and there can still be some microinstability,
right,
which can make things very difficult because then they start getting a lot of tendinopathies because their psoas is trying to compensate and be a secondary stabilizer to the pelvic to the joint. Their TFL or the rectus femoris is trying to compensate and trying to like secondarily stabilize the hip joint as well. And so you're constantly battling all these tendinopathies post-operatively.
yeah. So tell me, in terms of diagnosing that hip microinstability, I, for me, what the literature that I've read suggests kind of the best clinical test out there is abduction and then kind of giving them a little anterior glide at the femoral head, right? Putting them kind of giving like a posterior to anterior pressure. Is there a best clinical test out there for you, or is there a go-to that you use to kind of
Yeah.
see, obviously again you're trying to see if that reproduces some of their symptoms, with that. But
Yeah.
again, I feel like again, anybody that's symptomatic at that anterior hip, if you're driving the femoral head forward into some of those structures, it's probably going to irritate them a bit, I would think. Yeah. So,
Yeah, I don't know if you've tried that test or not. That's the type of test that works a lot better on paper
yes. Right.
than
Yeah.
it does in reality, right?
Yeah.
So, yeah, I think that's a really difficult test to procure and to really get down, honestly.
Yeah.
So, for me, there's no really great test again, other than just understanding, do they have laxity elsewhere in their body?
Generally. Okay.
And then what is their overall general range of motion through their hip, in terms of their internal external rotation. And it's just also kind of like a gestalt, right? There's just some people you're like, this person has microinstability. I just know it based on their body habitus,
Yeah.
on their structure, on the way their movement and their mechanics.
Yeah. Absolutely. I,
Yeah.
I totally see where you're coming from with that. if you could tell us a little bit about, we'll move kind of beyond that because you're doing the technical part of the surgery, but since we are probably a largely rehab audience listening, if you could tell us a little bit about what are some of the pitfalls you see with rehab of these patients, things that may not necessarily be done well when you see this patient at a 2 or 6 week follow-up coming back in your office.
So for me, what is absolutely critical is early range of motion,
Okay.
because I don't want them to start developing adhesions,
Right.
any stiffness. So that's why, like, with the protocol, honestly, thanks to you and your team and their support in helping develop it. Getting patients into PT within the first 2 to 3 days after surgery, getting them on a stationary bike without resistance, just to get simple motion going, I
Yeah.
think is really critical, because it's amazing how quickly they can get stiff.
Right.
Um, and so that's one pitfall. The second is, I think, underestimating the power of the gluteus medius and its impact and influence, right? So if you overlook any gluteus medius deficiency and weakness, then they're going to struggle, and they're not going to progress, because what will end up happening is that glute med deficiency is going to put excess stress on the TFL
Yep.
and on their rectus, and then they're going to have this persistent chronic, like, hip flexor tendinopathy that just lingers for like 4 months, and you're just constantly fighting it and trying to understand it. So I think that's another major pitfall, and something that kind of slows a lot of these patients down.
For sure. Yeah. I mean, I feel like that balance, yeah, similar to, I think, what we see with like rotator cuff, right? Where again, that ability to kind of suction the head of, in that case, the humerus, but in this case, the femur, right? And kind of maintaining that balance and that kind of homeostasis in the joint so you don't have that stress on one particular area is huge, right? And I feel
No
like
question.
there's so many structures involved with that.
Absolutely.
Um, so you mentioned the irritability of the hip flexors and how easily they can get pissed off and
Yep.
how long they stay that way. What are your feelings about in terms of when post-op is a good time frame to start hip flexor strengthening? And also, what are your feelings about how soon and how aggressively you stretch hip flexors? Or maybe I won't even say stretch hip flexors, but thoughts about some of those anterior hip structures and when it's safe to start kind of mobilizing, I'll say.
Yeah. So I think gentle mobilization of the hip flexors can start within the first week.
Okay. Yep.
Um, but I think you can get really more aggressive after like 4 weeks.
Gotcha.
At least that's
Okay.
that's my comfort level.
Yeah,
You guys are way more the experts than I am. Um, but at least that's how I feel. Enough healing of the capsule within the joint has occurred. And again, it's a balance between allowing things to still heal, and that joint to achieve its new homeostasis, while trying to kind of like move things along.
yeah. How about as far as when you feel like is a good time frame to start hip flexor strengthening, given the concerns about maybe aggressively pursuing it and irritating them in a way that again kind of ends up slowing down your rehab or causing an overall regression because you have to then allow everything to settle back down and almost shut them down for a while.
Yeah. So I think a lot of it is dependent on where the glute med is, in
Okay.
terms of strength.
Yeah.
Because I think that if you haven't quite established glute med strength, then you really shouldn't be pushing the hip flexor strengthening too aggressively or too quickly.
Yeah.
And so people are going to have a little bit of different time frames for that. So if someone has pretty good glute med strength pretty early on, then I think that gives you license to move ahead more aggressively with hip flexor strengthening.
Yeah. Okay. Oh, that's great. All right, well, I have taken up a ton of your time.
No, this is fun.
I
Doing
yeah,
fast.
I thank you very much for joining us on one of your first ever podcasts.
Yes.
Um, but if you could, Dr. Tabaddor, tell us a little bit. I mean, this has been awesome, and I think I know I've taken away a couple bits of insight already just by sitting here listening to you. But for rehab practitioners or listeners that want to kind of find out a little more about you and some of your resources, where can they go to?
They can go to the UOI website.
Okay.
They can there's resources under education on UOI, and then also on my particular landing page.
Okay. All right. Perfect. And any other, like, are you an active social media poster or not so much? Yeah.
I'm not.
Yeah.
I haven't. I, I guess I like my work to speak for itself.
Well, yeah, absolutely. And it sounds like with all your different hats, you're busy enough already rather than taking on marketing tools with social media. So
Yeah, I mean,
uh
maybe I can have my daughter take over that social
yeah,
media
right.
duty.
They're probably infinitely more tech savvy, right?
Yes,
So
yeah,
yes.
exactly.
So if you could tell us, this is one I always like to kind of get just kind of off the cuff here. If you could tell us a little bit about you that maybe our listeners can't find out from your UOI bio or your webpage. What's kind of an interest of yours or a fun fact that may not be listed there?
Um, so I'm an avid Marvel geek.
Oh, okay. All right.
Yep. There isn't a Marvel movie or Marvel like hero that I don't know.
Got it.
That's the kid in me that never left. And I'm a travel junkie. I love to travel. I love to explore. I love to
Awesome.
eat foods from all different places. So
Yeah.
if I can somehow merge my Marvel world and my traveling somehow together,
Yeah. You need to the Marvel World Tour, right? Now,
yeah,
are you like comic book collection also, or strictly movies, or like all of
it's
it?
yeah, no, not as much the comic books anymore
Gotcha.
as
Yeah.
when I was younger, but now more,
Yeah.
boy, just the movies and the shows and everything like that. So I know I probably turned off a lot of listeners by now, but
Yeah.
that's okay.
So where's next on the travel list? What's the next itinerary here?
So just got back from London, and I was in Iceland
Oh,
earlier in the year to check out the Northern Lights,
awesome.
and the next on my list is to get to Patagonia.
Oh, nice. Okay. Yeah. Argentina. Very nice. Okay. Awesome. Well, again, I've taken up a ton of your time. I thank you very much for kind of sharing some of your wisdom and insight here. And I'm sure the listeners thank you as well.
Yeah, I really appreciate this. This has been great, Dan. Thank you so
All
much.
right, cool. All right. Thanks again for coming on, Dr. Tabaddor.
Okay. Yep. Bye bye.
All right. Take care.